Go.
Вітаємо, шановні колеги, вітаємо,
Welcome, dear colleagues and dear friends. This is our second and final day of our 10th workshop on track to improve health of women living with HIV in Ukraine. And we are very grateful to all of you to join us. And we would like to say that this webinar was possible and was created by WAVE, which is part of the EX family. WAVE, which is Women Against Viruses in Europe. Yesterday, we were looking at PrEP in women in Europe and Ukraine. And today, we will concentrate our attention on HIV testing for women in Ukraine, in Europe in general. So we will assess the situation and challenges. But in the beginning, I would like to introduce our chairs. Annette Habel from Germany, Doctor of Medicine from Frankfurt, Germany, and she is the head of WAVE today. So hello, dear Annette. And also Carolina Abipop is with us today, Doctor of Medicine, gynecologist, researcher, Department of Infectious Diseases, University Hospital, Bern, Switzerland, and Svetlana Antoniak, infectious diseases specialist and researcher at HIV, AIDS, and viral hepatitis department at the Institute of Infectious Diseases, named after Gromashevsky. And the floor is to you, Annette.
Well, thanks, Sergey. Well, I feel honored now as WAVE chair to welcome all of the participants and, of course, all the presenters. And I'd like to thank all of you, but especially Carolina and also Svetlana and Sergey, because it's your thing, your baby, the Ukraine WAVE workshop. And I think it's great that it started well and it's so important and it's continuing. And today, I mean, yesterday, the PrEP session must have been great. That's what I heard. I will join it later and look at yesterday's presentations and discussion. But today, the testing is also a really important topic, I think, and missed opportunities. We have to discuss all that. And I'm looking forward to the presentation, to the case report. And I hope we'll have a lively discussion again today. And so with that, I give back to you, Sergey. And yeah, and once again, thanks to all the organizers and thanks to all the presenters, the speakers of today.
Дякую, Анет.
Thank you so much. Thank you, Annette. It's nice to hear very pleasant, nice, and kind words. It's true, we are very happy that in these difficult times, we still are having our webinars, and we have them a couple of times a year, so which is an island of peace during those unpeaceful times. And Caroline, now, please, you're welcome.
Thank you. Thank you very much, Sergey. Thank you very much, Annette, and a warm welcome from my side from Switzerland to all the participants and especially to all the speakers today. And Svetlana, of course, I thank you for organizing. It was really wonderful yesterday, and as Sergey said, it is an island of peace, and it is a very nice time to stay together and to support each other. WAVE is a fascinating group for me. It's so diverse by many people joining in from different regions, different specialities, community members. And as we heard yesterday, prevention is a very important topic, but as you know, it all starts with the right diagnosis or the diagnosis in time. And I feel that women are often left behind, especially migrant women or even like internally displaced women not offered a test. And I'm very glad we have chosen this topic for today. And we also heard that women sometimes cannot estimate their HIV acquisition risk. And so I'm really, really happy that it was the participants' opinion to choose this topic. And I wish you a very nice workshop. Thank you.
Дякую, Caroline.
Thank you, Caroline. Svetlana, Miss Svetlana. My wonderful, dear Dear colleagues, I'm very happy to welcome you at our 10th webinar of EACS on track to improve health of women with HIV in Ukraine. Thank you for showing your interest towards this topic, and thank you for finding time, regardless of your busy schedules, to spend this time with us for almost 2 hours and to be together and to talk about PrEP. Yesterday, HIV testing. Today, with a special focus on women. Special warm words about from Doctors of Ukraine to Dr. Annette Habel, and the chair of WAVE and chair of this meeting, chair of this webinar. She's been dealing with HIV, issues of HIV in women for many years, and also she's a member of the board of the German AIDS Society, and we remember that when you first came to Ukraine, you came with other German physicians to teach us Ukrainian doctors when we just started to provide care to HIV patients, and we were just starting to provide ART to our patients. A lot of the things were very new to us back at that time, and we remember those meetings, meeting you first time. And also, I would like to say thank you to Dr. Caroline Abby Pop, Master of Science, Doctor of Medical Sciences, working in Bern, Switzerland, University Clinic. And when she was the chair of WAVE back in 2019, Caroline, together with Justyna Kowalska, the professor from Warsaw University, and together with Professor Fiona Mulcahy from Dublin, they were those people who inspired our webinars. And Carolines, thank you for being part of all that, all our webinars since the first time. So first one was in Kiev, next one Lviv, and so over the last 5 years, it's been 10 webinars. This is the 10th webinars that we are having, just like Sergey has mentioned, like a small island of peace. I'm not a big specialist on testing, at least that's what I think of myself, but I'm very much helpful to our speakers, Dr. Charlotte Eve Shore, to Dr. Daria Podlekareva. Thank you for participating in today's webinar. So we see those webinars as a helping hand to Ukraine. That was back in the COVID times, and now during the difficult war times, we still continue our activities, although online, but we go on and we continue working. And also, we have a big team from Ukraine, Tatiana Yelagina. She is the head of clinical and diagnostic lab at Kyiv City AIDS Center. And also, I would like to welcome Natalia Ratushnyuk, the head of clinical diagnostic lab of Alexandrivska Clinical Hospital in Kiev. Also, Yelena Martinenko, and she is the head of outpatient clinic at Kyiv City AIDS Center. And Ina Lutsuk, she works at the clinic of the Institute of Epidemiology, named after Gromashevsky. And thank you to all of you for being part of this webinar and for presenting your presentation and cases. So thank you everyone for joining and for the ability to discuss important HIV testing issues with a special focus on women. And just a few words about situation in Ukraine, if I may, very briefly. So in Ukraine, currently, with a diagnosed HIV infection, we have 150,000 people. 116,000 are on ART. So our cascade looks like 70, 82, 94. We are far from being 95, 95, 95, but still we go on and we continue to work. So we continue providing HIV testing in Ukraine, both in healthcare facilities, and this is done through the 13 packages of care, and also rapid diagnostic tests are used also by family physicians and also by outpatient clinics, also at NGOs. At home, self-tests are done by oral tests, and you can order them free of charge in Ukraine. It is done thanks to the Alliance of Public Health. Also, we have a chat bot, and it shows how to find the closest to your HIV testing point, and it gives you information how to know your HIV risks and how to get tested at healthcare facility, at a friendly NGO, or at home. What I can say that in March 2024, recently in Ukraine, we've registered 1,038 new HIV cases, 264 cases of AIDS, and 82 persons died of AIDS. In April this year, we've registered 892 new HIV cases in Ukraine. 732 of those are heterosexual route of transmission. So probably 6 or 700,000 testing are done each quarter, and the efficacy is 0.5%. From 892 to 1,038 new HIV cases are registered. Most of those new cases are men. And again, during the quarter, 2,656 new cases, HIV cases, were diagnosed during Q1 this year. We continue to work, and the Public Health Center continues to collect statistical data. And among new cases, more than 35% are women. In the overall HIV cohort, women are 46%. And in 2023, 1,216 women with HIV gave birth to children. That was in 23. Regardless of everything, regardless of war. And unfortunately, 15 babies in 23 got infected vertically. And that was done, nucleic acid test, NET testing was done to diagnose them. So when we will be looking at the 2023 cohort, we understand we are going to have more cases than that, like for the 22, 31 babies. And that you wanted to ask something, right?
No, go on. I didn't want to interrupt you. Just wanted to suggest if you could provide these data on one slide after this workshop, because it's so interesting, but I just can't keep every number in mind. I'm old. Please, Svetlana, it would be great to have this on a slide. And I'm impressed that you continue to collect data and do all this testing, even though the war is getting worse. And I mean, wow.
All
right, Annette, no problem. I was just thinking that I will just give a welcome word, but then I decided, why don't I say a few words about our epidemic? So that is why I decided to give some figures. But of course, I will prepare it as a presentation, and I will send it to all of the participants. It's going to be my pleasure. Those are official data. They are already published at the website of the Public Health Center, Ministry of Health, Ukraine. These data are collected thanks to our field coordinators. So we do continue our work. And just to repeat, 600,000 or 700,000 testing were done in the first quarter, 0.5% of positive results. About 1,000 new cases per month are identified, and 13 babies unfortunately acquired HIV out of more than 1,000 babies born in 23. I just wanted to give you just a few words about our epidemic and give you some absolute numbers because it's perceived well. Also, I would like to say thank you really very much to all of the participants from Ukraine, because regardless of the difficult times, just to repeat, we are still working together. And Since 22, we get together every week. We are looking at different clinical cases, regardless of the blackouts. Sometimes we don't have power, sometimes no internet, but still we do that. We get together and work. And we care about prevention in the context of HIV testing in order to provide ART as soon as possible and other necessary services as needed. And we will hear more about that because we have a very good specialist, laboratory specialists will be talking today, and two clinicians. Hopefully our discussion is going to be really interesting. And sorry for taking more time, but I just thought it was important to start with some figures. And Sergei Antoniak is going to be our moderator. He is a research and scientific worker at the HIV AIDS and the hepatitis department at the Institute of Epidemiology, and also he is a member of the WAVE committee. That's important as well. So thank you. That's all. Thank you for your attention. I'm done. Thank you. Thank you, Ms. Svetlana. True, our epidemic is kind of different, a bit different from the epidemic going on in other and many other European countries. It's important to understand our epidemic, and women's health is of relevance. So just a few words about our agenda and more introductions to come. So let's start. We will start first from the mini lecture HIV testing, who, when and where, focus on women, and this is going to be provided by Daria Podlekareva, Doctor of Medicine and Associate Professor from the Excellence Center, Health Center, Copenhagen University Hospital, Department of Respiratory Infectious Diseases. So it's medical faculty, Copenhagen, Denmark. Thank you, Daria, for joining us. And after that lecture, we are going to have a short Q&A session. Here, what I would like to say, that you can leave your questions in YouTube in the chat at any time during the lecture or during the discussion. Please put your questions there. We will do everything possible to cover all the questions. Then we will go on with another mini lecture, HIV testing in women. It's going to be provided by Charlotte Eve Short. She's a Master of Medical Sciences, clinical lecturer of the diseases of HIV and STIs, Imperial College of London, from Great Britain, from the UK, Charlotte. Thank you for joining us today. And after this mini lecture from Charlotte, we also are going to have a short Q&A session, and then we will continue with a case, clinical case, HIV testing services in the case of a woman planning pregnancy. Very interesting case, very controversial. Hopefully you will like it. So it's going to be provided by Ina Lutsuk, infectious diseases specialist from HIV/AIDS department and viral hepatitis at the Institute of HIV viral hepatitis, named after Gramashevsky. And there'll be another presenter, a very wonderful specialist in lab diagnostic, Tatiana Lagina. She is the head of diagnostic lab at Kiev AIDS Center. And after that clinical case, there's going to be an overall discussion, and will be joined by other specialists, the head of the clinical diagnostic lab from Alexandrivska Clinical Lab in Kiev, Natalia Ratushnyuk, and also will be joined by Olena Martinenko, Infectious Diseases Hospital, and the head of outpatient department of Kiev AIDS Center. So we have a powerful team, diverse and powerful team. The only thing to remind that the recording of this webinar is going to be available for a couple of more weeks. So maybe if someone will miss today's webinar, but it will be possible to view it during the subsequent couple of weeks. So let us start with our first lecture, HIV testing, who, where, and when. Ms. Daria, you are welcome.
Hello, my name is Daria Podlekareva, and I'm an infectious disease consultant working in Copenhagen in Denmark. And I've been involved in HIV research for more than 20 years by now. And I would like to start by thanking the organizers of this WAVE in Ukraine webinar for opportunity to participate and to make this presentation for you. So my presentation is about HIV testing with focus on women. And I would start to talk about general considerations for HIV testing. So why in general we need to test people for HIV. I'd like to start by presenting you with this clinical case. We are talking here about a 38 years old woman who is followed by her general practitioner for hypertension. She goes to routine blood test, which shows a mild normochromic normocytic anemia with a slightly raised erythrocyte sedimentation rate. There were no any follow-ups on this blood test because she was feeling very well. But then 2 years later, she was admitted to hospital with severe pneumonia complicated by pleural effusion requiring drainage. And also she continues to have anemia here, and that's why she was scanned in her chest and also abdomen, which we know there was a pneumonia in her lungs, but CT abdomen reveals a variant cyst, and she was referred to the gynecology department. She was found to have a high-grade superficial intraepithelial lesions of the cervix and also cervical neoplasia. She received treatment for this and also outpatient follow-up. But she continues to be anemic, and etiology of this anemia remains unclear. So she is referred to gastroenterology department for coloscopy and gastroscopy. And coloscopy was normal, but gastroscopy revealed esophageal candidiasis. After that, a gastroenterologist performed an HIV test, which turned to be positive, and at that moment her CD4 cell count was 30 and HIV viral load was 51,000 copies per milliliter. So I hope you can see here a lot of missed opportunities, and you realize that this patient was diagnosed late with HIV already on 8th stage. Evidence shows that when individuals are diagnosed with HIV infection, they decrease their risk behavior. And HIV patients taking effective treatment are very unlikely to transmit HIV. And also people who remain undiagnosed do not have advantage of either of these two factors. So they continue the risk behavior and they continue spreading infection, and it's also not beneficial for their personal health. Also, modeling studies from United States some years ago showed that those who are unaware of their HIV infection are primarily responsible for spreading infection further to their sexual contacts. So why do we need to test for HIV? There are three main reasons why it is important. The first is direct health benefit to the individual. Once diagnosed, they can access very effective treatment and thereby avoid significant morbidity and mortality. The second is to reduce onward transmission to partners. Once a person is diagnosed, they typically modify their behavior to reduce risk. Furthermore, once an individual starts treatment and achieves an undetectable viral load, they are considered to be non-infectious to sexual partners or as we call it, U equals U, undetectable equals untransmittable. And finally, early diagnosis also reduces healthcare costs as it avoids the morbidity associated with untreated HIV and thereby reducing healthcare costs. So on this slide, you can see a schematic drawing of goal of routine HIV screening. So when we screen population for HIV, we aim to establish as many HIV diagnoses as possible. And then it is very, very important to link those with positive HIV tests or HIV diagnosis, to link them to care, and both for medical care and also for prevention services. Once these persons are linked to care, it is very important, it is essential to continue and to continue healthcare linkage and continue active follow-up, which will improve survival and quality of life of HIV population and also prevent for new HIV infections. So the next couple of slides will show you benefits of early HIV detection versus late presentation. Data from recent ECDC and WHO HIV/AIDS surveillance report in Europe, based on data from 2022, shows that more than 50% of all newly diagnosed HIV infections in Europe were in people with low CD4 cell count, or so-called late presenters. And the proportion of late presenters was highest among people above 50 years of age and among males who acquire HIV by a heterosexual contact. What I find even more striking is that this proportion of late presenters in Europe is stable during the last 10 years. So there is definitely need for actions to improve the situation and to identify HIV positive people early in their disease stage. This graph shows you a progress towards 95-95-95 goals among women, as our workshop today focuses on women, so I decided just to take this part of the report, and we focus here on Eastern Europe and Central Asia. So the first part of the graph is the first 95, and it's percent of people living with HIV who knows their status. We can see here that the proportion of those is only slightly improved since 2017, and in 22 it was around 70, just above 70%. So there is a lot of space for improvement here. So who should we test for HIV? There is an approach where healthcare professionals routinely offer an HIV test to all individuals presenting with an indicator condition because the condition is associated with undiagnosed HIV. Studies indicate that routine HIV testing is cost-effective when undiagnosed HIV prevalence in individuals with a specific indicator condition is more than 0.1%. And the concept of indicator condition guided HIV testing is an approach where healthcare professionals can be encouraged to offer tests to patients based on the presence of an indicator condition rather than risk behavior or group. This potentially addresses many of the barriers felt by patients and healthcare providers to HIV testing. So what are the indicator diseases or indicator conditions? There are three main categories. First of all, it is conditions which are AIDS defining among people living with HIV. Secondly, it is conditions associated with an undiagnosed HIV prevalence of more than 0.1%. And thirdly, it's conditions where not identifying presence of HIV infection may have a significant adverse implications for the individual's clinical management. So I will go through all these three categories shortly in the next slides. And I hope you're all familiar with AIDS-defining conditions. There are 26 of them, comprising both infections and malignancies. So actually, you can see that if you go back to our clinical case, this woman, she was diagnosed with cervical cancer, which is AIDS-defining condition, but she was not offered an HIV test at this stage. Here we have conditions that are associated with an undiagnosed HIV prevalence of more than 0.1%. And you can see the list here, but I would like to underline here sexually transmitted diseases, hepatitis B and C, and also pregnancy is on this list. And here not diagnosing HIV during pregnancy will have major implications not only on the woman herself, but also for an unborn child. And here is a list of other conditions considered likely to have an undiagnosed HIV prevalence of more than 0.1%. You can see the list of all of them here. I will not go in further details. So what are the consequences of late diagnosis? There are three major consequences of being diagnosed with low CD4 cell count or with AIDS-defining conditions. And they are increased mobility and mortality, of course, also increased onward transmission and increased healthcare costs. And I hope you are all aware about, or you have all seen this slide before, very well showing a beneficial effect of antiretroviral therapy. And the effect of antiretroviral therapy since its implementation in the late 90s was tremendous and cannot be overestimated in respect of morbidity and mortality in people living with HIV. Now I will go further on HIV testing and HIV testing services. And there are several organizations at international, regional, national, and specialty levels producing HIV testing guidelines. Here you can see WHO guidelines. They've been published several times with several updates, and the latest version is from 2019. And I will advise you to find it online and go through it in details. But I would like to underline several important aspects of these guidelines within the next slides. So chapter 6 includes a special subchapter dedicated for pregnancy and pregnant women and children. It is a very important aspect of HIV testing and very important also chapter in these guidelines, because elimination of mother-to-child transmission of HIV and also other infections such as syphilis and hepatitis B is a global health priority. All pregnant women should be tested for HIV, syphilis, and hepatitis B at least once in their pregnancy and as early as possible. WHO recommends combined tests for HIV and syphilis. And when we test early, it will enable maximum benefit from prevention, treatment, and care, and it also reduce risk of transmission to infants and sexual partners. Also, early treatment of HIV and syphilis and also hepatitis B will lead to the best health outcomes for mothers and children. Antiretroviral therapy, as you all know, is the most effective in prevention HIV transmission from mother to infants, and the earlier we start, the greater benefit is. And also in high burden settings, high HIV incidence is seen throughout all antenatal and postpartum period, indicating that retesting may be warranted for pregnant women who initially test HIV negative. I will come back to this point in just a couple of slides. So further guidelines recommend that efforts to provide and expand HIV testing services should prioritize population most affected by and a high ongoing risk of HIV, and including those with specific individual or structural vulnerabilities. HIV testing services efforts will work best when designed specifically to address each priority population needs and preferences. So you can consider one strategy to, for example, pregnant women, and another strategy to a different risk population, as, for example, sexual workers. The populations that need to be considered for prioritization in a particular setting depends on local epidemiology. So it's in general, it is key population and also their partners. It's men, adolescents, and young people. It is pregnant women, infants, and children. Also, serodiscordant couples, sexual and drug-injecting partners of people living with HIV, migrants, refugees, displaced population, and so on. Again, pregnant women should be tested for HIV, syphilis, and hepatitis B at least once during pregnancy. And here you can see a table with recommended time points for HIV retesting for pregnant and postpartum women. So again, I repeat myself, early in pregnancy, all pregnant women should be tested irrespective of it is high or low burden settings. But in high burden settings, retesting late in pregnancy should be performed as well. Or in low HIV burden settings, it can be considered. And then an additional test postpartum can be considered for those at ongoing high risk, particularly in high HIV burden settings. WHO also released special guidelines for dual HIV syphilis rapid diagnostic tests, and it can be used as the first test in antenatal care, so the first test during in early pregnancy. There is a very nice flow chart on how to perform and interpret results of this dual test, depending on whether it is HIV and syphilis positive and negative. So I will not go into details, but you can find these guidelines online and follow this chart depending on situation. When we plan a strategy for HIV testing, there should be different approaches and different settings should be used. So when and where HIV testing can be performed, it can actually take place at all levels of the health system, as you can see at this diagram. So this figure depicts how testing services should be organized and shows different HIV assays on the left part that can be used for each setting. Ideally, HIV test services should be located and easily accessed at people's first point of contact, as for example here in community and outreach, and here it is very important to involve community workers, social workers to help patients in testing. And then also primary care should include HIV testing as a routine. And the next levels are on advanced healthcare facilities with clinical laboratories. So when we design service delivery for HIV testing, we need to consider different approaches and preferably combination of these approaches. So HIV testing services need to focus on people with HIV who remain undiagnosed. So we need to go out to risk populations and find those undiagnosed cases. And we should focus on diagnosing and linking to care. So it's not enough to have a bus somewhere out in the city doing testing. There should be also a setup how to link to care those who've been tested positive. Approaches to deliver HIV testing services can include facility-based, community-based. HIV self-testing is also very important, and also voluntary HIV partner services, including provider-assisted referral and social network-based approach. As I mentioned, we need to mix different approaches, and integrating HIV testing services should be prioritized. So here we need to integrate with testing for other infections, as I talked earlier, with, for example, STIs, syphilis, tuberculosis, hepatitis B and C. We need to integrate HIV testing services into reproductive, maternal, newborn care, postnatal care, and family planning services and care. Also services for key populations, and screening and care for other conditions, including non-communicable diseases. I already talked about involvement of community into, and social workers into testing services. Once again, underline implementation of HIV self-testing. It is also very important. Voluntary HIV partner services remain effective in identifying undiagnosed HIV infections, and social network-based HIV testing can be offered as an HIV testing approach for key population as part of comprehensive package for care and prevention. So to summarize, who should we test? Actually, CDC guidelines says that everyone between ages of 7 and 64 should get tested for HIV at least once during their life. And of course, people with certain risk factors or risk behaviors should get tested more often. Risk populations should be tested at least once a year. All pregnant women and children born from HIV positive mothers should be tested, and those with indicator conditions and AIDS-defining diseases should, of course, be tested. Otherwise, perform HIV test upon indication. So, when do we test? All pregnant women should be tested at least once during first trimester, and in high burden settings also late in pregnancy. Risk populations should be tested at least once a year, and all other upon indication. And where do we test? Possibilities should be very broad, and very broad spectrum of testing opportunities should be available. As we discussed, from self-testing and community-based checkpoints to advanced healthcare facilities. This was my last slide, and thank you very much for your attention.
Пани Дарья, огромное
Ms.
спасибо.
Daria, thank you so much for this very informative, for this very interesting presentation that covered quite a big spectrum of issues. Thank you once again. Thank you very much for your participation and your presentation. And now the questions. So we will have a look. So we will have a look in the chat. Tatiana, you're most welcome. Hello, dear colleagues. I would like to ask, with regards to, there was a slide with a pyramid of testing from level 0 to level 3 or 4. So I would like to ask on which level it is worthwhile to use rapid diagnostic tests for diagnosis. Well, of course, level 0, we understand it's rapid test, oral test, but then later on, where do we use rapid tests and where do we use the instrumental diagnostic tests? Thank you. And actually, this is a question not only to a presenter, but maybe to everyone who would like to voice his or her opinion. Tatiana, thank you very much for this question. I am very sorry, but my Ukrainian is not perfect, but it's okay. You can use Russian. So we are talking probably about on which levels do we use intervention tests? As far as I understood, I will translate it. Well, I will say it in Russian again. I will say it in Russian. What I meant, on which level of testing do you use rapid tests, and on which level of testing instrumental? Where do you use instrumental lab tests? So thank you. In principle, rapid tests can be used on any, or all levels, even in clinics on a hospital level. Also, you can use rapid tests as well. So if it turns positive, in any case, you have to repeat it, whatever level it is. So whether it's a bus somewhere on a bus stop and the rapid test is positive, so in this case, still you can take the patient to take the client to the hospital and do the confirmatory test. In Copenhagen, we do use rapid tests. For example, they come just from the street and they ask for rapid tests. So we use rapid tests, and very often combined tests with hepatitis B and C are also used. I will clarify. So you do screening tests with rapid tests, but confirmatory with instrumental ones, or you do confirmatory with rapid tests? Yes, confirmatory instrumental tests. Perfect. Thank you. Thank you very much. Thank you. Annette, you're most welcome.
Yeah, first, thank you, Daria, for this comprehensive presentation. It was so great, so much information. And I was just wondering, you showed this excellent case in the beginning to show the missed opportunities in HIV testing. And then later you presented data from the US with this people living with HIV and who are unaware of their status. I think it was about 25% who then later on transmit the virus, and we have 54% of new infections. And you said it's they, and I don't blame you in any way, but the wording, what they are responsible. And I was thinking, are they really responsible? No, they are not. I think we as doctors are responsible, because as your case showed, there are so many missed opportunities where doctors just don't look at indicator diseases, don't even think about HIV. Of course, it depends on the prevalence on the level you live. Like in Germany, we have a very low HIV prevalence. So most likely this woman would not have been tested in Germany either, and it would have been a late presentation. And we see this late presentation, and even in Germany, we fail the first 95, because 10% of the people living with HIV in Germany are still not diagnosed. So you see, this is really the challenge. And talking about responsibilities, I would like to open the discussion and say, what can we do that more doctors think about HIV testing and offer it early enough? Because I think it's not a fault, but it's our not thinking about this opportunity. It's not about the people who are not aware of their status.
You are absolutely right, and yes, it is a word in sort of responsible. They are not responsible. Yes. And we usually say, don't blame the patient. It's not patient responsibility, and it's our doctor's responsibility. We are much more responsible than the patient, and we need to build up infrastructure and system where patients, irrespective of their lifestyle, should feel themselves comfortable and should be tested.
Дякую. Шарлот хотела что-то задать.
Thank you, Charlotte. Did you want to ask a question? No.
I was going to just say as Daria did, so continue.
Сергій.
Анет.
Sergey?
So it's just a quick question. If I might add it, Daria, you talked about this combined testing of HIV, syphilis, and hepatitis B during pregnancy. So, what is your personal opinion about adding hepatitis C in some settings?
I think it will be a clear benefit to add hepatitis C, and also especially in high burden settings and in settings where injection drug use is a main driver, and as a consequence of injection drug use in the heterosexual contacts are main drivers of epidemics. So it definitely would be a benefit.
Дякую.
Thank you. Thank you, Ms. Daria, for this wonderful lecture. We have more questions in our chat from our participants. And who makes the diagnosis of HIV infection? On one of the slides of your presentation, so first the diagnosis is made and then linkage to care is done. Okay, and because of that combined question, there is more questions. Who, where, and how is providing the post-test counseling in case of HIV positive result? So if I may, I will answer in Russian. Yes, of course. Yes, absolutely. You can answer in Russian. I think that traditionally, this is the infectious disease specialists. They are the ones to make the HIV diagnosis and do the post-test counseling as well. It depends on the setting and depends on who is managing the HIV positive patient. For example, like in Denmark, if we see the test is positive, the person is referred to infectious disease specialist. Some of them are case managed, some just come on their own. So we do confirmatory tests and counseling. Counseling includes talking to an infectious disease specialist where we tell them about the necessity, need of ART and subsequent steps of follow-up and treatment, and also done by a nurse. Counseling with a nurse and by a nurse is very important. And usually, nurses talk to patients easier, so to say. So I know from my own practice, like a patient might be with me for 5 or 10 minutes. So we've done things and he goes on to talk to a nurse about their life, family, partners. They're more open with the nurse. So it is really important to do counseling by a doctor and a nurse. Because a person might have some social issues or challenges, then we involve social workers as well. Thank you really very much. I think maybe we will come back to talk about that after the clinical case. And on one of your slides, there was a screening first and then diagnosis, HIV infection diagnosis, and then referring to care. Even if we do verification, so somehow the patient has to get to care, has to be linked to the care since the time he was verified. And very important, when a person already heard the word HIV, we need to understand that it's difficult for the person to perceive any further information because they are shocked, especially if it's a woman. Women are shocked. So we need to take that into consideration. So we have to do the counseling when the blood is drawn, when the first positive result is received. So this is the time when a person is able to objectively perceive the situation and think about options. What will happen if we do this or that? But I think we will come back to that when we talk and discuss the clinical case, because often it looks like that the laboratory diagnosis is done in one place and the counseling is done in a different place. So we need to kind of survive that period of time. I understood what you mean, dear Svetlana. Of course, if it's done in a testing location, some kind of a street bus where the testing is done. So the person who is doing the test, and usually those are, of course, rapid tests, they need to be trained how to inform inform a person about HIV positive test. And if a person wants to be tested voluntarily, then it is expected that he or she might understand that it might turn positive. But although shock is very natural, and it's important for a nurse or social workers need to be really trained to support a person psychologically, how to correctly inform about test result and how to correctly word it, that you need to be linked to care and go on further. Thank you very, very much. Thank you. Thank you. Caroline?
I was just wondering that the testing is also done, for example, I'm working in a colposcopy clinic with cervical dysplasia. And I think it's very different what time you use to test. But I was, in regard to the representation, I was a bit puzzled by the age of 64 that we should stop testing. I think this is maybe to discuss, because why should we stop at 64? I think women will be sexually active after 64. Maybe this was when you have a lower life expectancy, but for now, I think it's really depending on the history. And that is why we, as we said before, we doctors, we are the person where you can talk about your history openly and confidentially. And then this makes us also be the place to offer a test. This is just a short comment.
I had a woman, she was tested positive in age of 86.
Анет, так, я
Yeah, good to hear about that.
дуже
that
дякую,
woman.
Анет.
I just want to strongly agree with Caroline that we should not think about the age so much, but about the risk. And so even the recommendation to test once in a lifetime from 13 to 64, I mean, it does not even make sense to test every person. I think we really should look at the individual risk, at indicator disease, whatever, but just just once in a lifetime, then it's done, and then you don't look for HIV anymore. I mean, that does not make so much sense to me. And even looking at older women or mature women, whatever you call it, they don't need birth control anymore. They don't need might not need a condom or use a condom, and they go to high prevalence countries. So in these settings, it makes sense to test even older people, especially women. Just comment and to underline what Caroline said, and Daria just added an example.
Дякую, Анет. Нам треба рухатися.
Thank you, Annette. And we need to move on according to our agenda, because we are lagging behind a little bit. And 100%, yes. And moving on, and we have the next mini lecture, HIV testing in women, and going to be presented by Ms. Charlotte Eve Short. You're most welcome.
Thank you for the introduction and the invitation. I'm a clinical academic working in the field of HIV and sexual health at Imperial College in London, and I'm passionate about all things relating to women's health. So this background slide is just to highlight that half of people living with HIV globally are girls and women. And UNAIDS estimated in 2022 that of all the new infections that year, nearly half were in girls and women. We globally have not yet reached the first 90 of the fast track targets that were established in 2016. Although some countries have reached these targets, the current number or percentage of people who are unaware of their diagnosis globally is 86%, which means that 14% of people are undiagnosed. And this is a really important group to target because they're more infectious and have a big part in driving the epidemic. Now, we've got some ambitious targets to hit by 2030 of 95, 95, 95 by scale up of HIV prevention tools and programs. And if we manage to do that, modelling suggests that we could get to less than 20,000 new infections. Fast Track have highlighted that there are 30 countries that account for nearly 90% of all new infections. And the list of those countries is in the bottom right-hand side of the screen as you look at it. And just to highlight that, Ukraine is one of the countries listed in this box. I'm from the UK, and I will talk more about our population and HIV diagnoses towards the end half of this presentation, but I just want to highlight a slightly concerning thing that we've seen reported from our UK Health Security Agency, which does all our HIV surveillance, that whilst you can see in the last 10 years, we've had dramatic reductions in new diagnoses in gay and bisexual men who have sex with men, in the dark blue line. In the dotted dark blue line, which is highlighted in the red circle, we've had an increase in the last year in diagnoses in women. So how are we going to hit these 95, 95, 95 targets? Well, we're going to need to scale up every single HIV prevention tool that we have, of which there are many, but I'm here today to talk about HIV testing, which is an important prevention tool. And the reason we should think of it as a prevention tool, because it's really important in case finding these undiagnosed and new primary infections. And it's really the gateway to both the prevention tools and treatment as prevention. But having all these tools is not enough alone. The implementation of the tools and the programming behind that is really going to be key, and it needs to be tailored and targeted to high burden populations, including women. So I'm going to move track a little bit now, just to give an overview of HIV testing. And firstly, with the technologies. The first test we had for diagnosing HIV was a first generation ELISA test back in the 80s. And then soon after that, we had Western blots. For the last 30 years, nearly, I think, we've had a much more sensitive test, which is really the first line gold standard for the diagnosis of HIV, which is the fourth generation test, which is a combination of antibody testing with a protein P24 antigen that is expressed by the virus much earlier on than the antibody's response to the virus. So that can increase the sensitivity of the test and reduces the window period down to 4 to 6 weeks. We also have molecular tests, so most of us will be familiar with RNA testing. It's not available all around the world, but is available in many countries in the setting of which we are. Mainly we're familiar with it as a sort of treatment response monitoring, but it can be a useful test for people who you suspect is having primary HIV infection, because this RNA will go up before the P24 antigen. And often if we suspect that, we will do both an RNA and a fourth generation blood test. We also have in the molecular category poviral DNA, genotypic tests, and more latterly with the next generation sequencing technology, we're able to look at the virus at a strain level. We also, for the last 20 years, have had rapid tests, which have been utilised as point of care or home tests, and they can be blood or oral tests, traditionally based on antibody tests with a bigger window period of 3 months. But we now have some combination 4th generation point of care tests. And I think at this point, it's important to just distinguish when we're talking about home testing and home sampling, that they theoretically are slightly different things. So home testing refers to a rapid test done at home, whereas home sampling is where you take the blood sample at home, but it can get sent to the lab. So moving on to the future is multiplex testing for more than one infection, miniaturized testing. I'll talk a little bit more about the digital support tools, which are really key in expanding linkage and can be really useful with HIV self-testing. And the future is omics and AI. So in terms of where some of these tests can get done, certainly in terms of the point of care tests, they can get done in any setting. And although this is a quite old diagram now, this is just to highlight that HIV testing can occur throughout the continuum from home, community, outpatient clinic, peripheral labs, all the way up to the hospital. But we're talking about HIV testing in women. And I think it's really important to acknowledge that women have far more barriers to testing than men. And some of those barriers you can turn over and look at how you can approach that to make them sort of facilitators when you're thinking about programmatic design. But I think I could consider that there are sort of 4 main categories of barriers that I've divided here into individual level, household level, community level, and structural barriers to HIV testing for women. And I won't read all of them, but just to pick up on a few examples. So an individual level, your own perception of risk associated with your health literacy is really important in identifying that you're somebody that could have an infection and going for an opt-in testing approach. Stigma and fear and discrimination really sit across all of these levels and are a real barrier to women testing. And language and culture can be a barrier as well. Many of the women, certainly in the UK, that are testing, newly testing positive, are migrant women. And designing our programs with this in mind is really, really important. I think with any design of program and health messaging and peer networking can be a kind of an antidote, if you like, or a way of tackling language, culture, and poor perceived health risks. Moving forward, there are some household factors that should be considered specifically for women. So there's the general things such as socioeconomics, poverty, ability to transport yourself to a healthcare setting, but having dependents, having children, caring responsibilities, or perhaps being in an abusive or coercive relationship can be really, really limiting in accessing some of these tests. And structurally, cost, access to healthcare services, health policy, and immigration status are big drivers here as well. So when we're designing any program of HIV testing, we really need to be quite targeted, but consider the local HIV prevalence, populations, and the services available. And we can think of HIV testing, I guess, in 2 ways: opt-in testing or opt-out testing approaches. And the first 4 headings on the right-hand side of the screen are opt-in testing approaches. So you can have provider-initiated approaches within hospitals, sexual health services, termination clinics, where testing is either offered based on risk or indicated conditions. This can also be done in the community with your family doctor or through outreach programs targeting specific groups. Partner notification, obviously, is another way that people are highlighted that they may have been at risk of infection and to get tested. And self-initiated tests through any of the above settings, but also at home, are going to be an important part of scaling up HIV testing. So many people prefer to test in the privacy of their own home. It's a supported approach by the WHO, but self-testing is not available in all settings. And I'm going to talk in a couple of slides about some of the successes of self-testing, particularly in combination with digital linkage. And opt-out testing is an important strategy in tackling some of the gaps in the people who we're targeting, because by mere fact that it's opt-out, apart from antenatal testing, which specifically tests pregnant women living with HIV, you're not so much as directing the testing against particular groups and sort of taking a whole wide approach. And that can be very good at tackling particularly sort of gaps in HIV targeted testing. And I'll talk some examples at the end of this presentation. So digital supported self-testing. This is results from a quasi-randomized controlled trial that was set in Africa. And they were looking at HIV self-testing, either supervised or unsupervised, compared to the standard of care, which was testing in the clinic. And all of the home testing, the self-testing, was done in combination with this HIV Smart app, which was able to interpret the results of the test, provided counselling, and also was able to link to care as well. And interestingly, in the self-testing group, the preference was for unsupervised, so the sort of the privacy of unsupervised testing. But self-testing itself provided a really high linkage to care in use in combination with the Smart app. And they were able to show in this study that this approach was superior in identifying new HIV infections with a relative risk of 1.3 compared to standard of care. But what's really nice about this study, and why I've included it, is that the women were the change agents in this study. So the index women cases were inspiring the men that were in their networks to get tested. So we've been asked to talk about some of the things that happen in our local populations in our countries. And I've shown you this slide at the beginning where we can see that since 2021, from the data period that was captured up to 2022, diagnosis rates in women in the UK increased by 61%. And half of these women are diagnosed late with CD4 counts of less than 350. We know that's associated with a higher mortality. And many of the women that fall in this category in our setting are migrant women. This gender-specific separation of data has only really been available since 2015. And aligned with this, and even more concerningly, the drop-off that we've seen in HIV testing that occurred during the pandemic has not picked up again in women. And rates for 2022 were still 19% lower than they were in 2019, which you can see highlighted in the red circle on the right-hand side of the screen. And that was compared, if you look in the line above, to a 23% increase over the same period in gay and bisexual men. Also alarmingly, in terms of looking at the uptake of testing in people that are offered tests in clinic, the uptake rate for women is much lower, so 38% compared to 74%. And this testing was being done in both non-specialist and specialist sexual health settings. So moving on to our case studies. So I'm going to cover three testing approaches that we undertake in the UK, starting with prevention of vertical transmission. So many countries in Europe have antenatal screening programs. Ours in the UK is an opt-out screening program that tests both for HIV, hepatitis B and syphilis. And that was introduced in 2000. And that, in combination with effective triple therapy to prevent vertical transmission, we have managed to reduce and sustain our rates of vertical transmission to less than 1%. And they're currently sitting at about 0.25%. So great success. That was over 20 years ago. But we actually have another example of a less directed towards women, but still very, very beneficial to women, another opt-out screening program. So in April 2022, we launched bloodborne virus screening in emergency departments in high prevalence settings. So this has been funded nationally, and areas where there were a high prevalence defined as greater than 5 people per 1,000 were targeted. So we have 4 cities where this is the case: London, Manchester, Blackpool and Brighton. And there were 34 EDs within these areas that were targeted for opt-out testing. And to be tested, you had to be having a blood test for another reason in the emergency department. And there were posters like this one here on the right-hand side of the screen, advertised all the way through A&E, basically saying, if you're having a blood test, we are going to test you for these viruses. If you don't want to, let us know. And so it was truly opt-out. Only 1 vial was taken, and we could test for all 3 viruses, and the tests are listed here on the right-hand side. All non-negative results were managed by the hospital, either through hepatitis or through sexual health and infectious diseases, and that enabled linkage and re-engagement in care. And there was monthly reporting from different sites and a sort of dashboard of the whole programme. So this is our 2-year data that was recently presented at our British HIV Association conference. And we can see that there were 3 million ED attendances over this time period with a blood test. And of those 3 million, nearly 2 million had HIV tests performed, 1 million hepatitis B and 1.4 million hepatitis C. Just the discrepancy in numbers here is because of the way the funding was established, and not all centres were doing tests for all of them. But there were 28 type 1 EDs in London that were offering virus screening for all 3. And moving to the table on the right, you can see it's a hugely successful programme. So we've identified over 4,500 new infections. And in addition to that, over 1,000 people who were previously diagnosed but not linked with care who have been linked to care. And the number of tests needed for 1 diagnosis for each of the 3 different viruses are highlighted in the furthest right column. And finally, I just want to talk to you about HIV Testing Week. So this is self-testing in the UK. We have a very successful social media campaign. So the actual programme is called Start With Me and I Test. And it's run through lots of different NGOs, including the Terence Higgins Trust. And you can, in this week in February, you can go online and you can, depending on where you are in the country, you can either order home sampling or a home test. And the results can be fed back into the programme, and you can be linked with care if they're positive, or there can be ongoing prevention messaging as well. And this is a nice example of a poster demonstrating a woman saying that she tests. So there's many faces on these posters. So finally, going forward with recommendations. So Fast Track recommend the following things for HIV testing, so that we re-examine current approaches and broaden testing approach options, because I think choice of testing, both in terms of test and location, is really important. So they suggest there should be community-based and self and home-based testing options, event and location-based testing, and community mobilisation for testing. And they suggest we use public and private partnerships and voluntary and provider-initiated counselling, and really direct to the most affected populations. But I also think that I wanted to present to you today something that some recommendations about migrant healthcare that was actually published in HIV Medicine earlier this year as one of the WAVE projects. And although this isn't directed at HIV testing, I think it is relevant because it's part of HIV care. And many women living with HIV in Europe are migrant women. So the recommendations relevant to HIV testing from this particular piece of work, that we should be designing more education programs for patients and healthcare workers to identify that migrant women are at risk of HIV, to improve their access to healthcare, which also actually does include overcoming language barriers and involving community members and using outreach programs, but also having services dedicated to women and to migrants. And fighting stigma is going to be, is such a huge part of HIV prevention and treatment. So that's where I'm going to end the talk, and I'm going to come online to take questions.
Дякую, пані Шарлот.
Thank you very much. Thank you, Ms. Charlotte. Wonderful presentation, very interesting, very diverse issues covered, and You talked about involvement of women, self-involvement, and a lot of other aspects included. So you're most welcome, Tatiana. Thank you, Ms. Charlotte. The presentation was really, really interesting. So I thank you for this for this presentation, and just wanted to ask whether in the UK is there any nationally approved testing protocol like screening, verification, identification? Is there such a protocol, number one? And number two, whether rapid tests are used in the UK to test pregnant women? Thank you.
So thank you very much for your questions, Tatiana. The first was about what our kind of protocols in the UK are for testing. So we have national guidelines from our British HIV Association. And just like the WHO and Daria presented, our first line is a 4th generation test. And this will always be confirmed with a secondary test. And that's what we use to diagnose. And like I mentioned in my talk, if we are suspecting seroconversion, in our clinics, we will also do an HIV RNA test. In regards to rapid testing, we use these in a number of scenarios in the UK. So most commonly in my practice, so I am a genitourinary physician, which is relatively unique to the UK, I understand, in that we are infectious disease specialists that does deal with STIs and HIV. And probably our most common use for this test would be somebody in clinic who is at risk of HIV in terms of their behaviors. And what we would do if we want to start PrEP, but they haven't had an HIV test within the last month, we always send a 4th generation, and we can normally get the results back quite quickly. But if we think that we want to start them on PrEP there and then, we will do a rapid test. I would say that we would never do a rapid test really in any scenario without a 4th generation. We don't tend, it's in terms of in the hospital. When we're able to do phlebotomy. In pregnancy, I think this is a very important question, because I think we have a lot of questions about testing in pregnancy and a lot of anxiety about people who book late and whether we should be using the test in that scenario. Currently in the UK, there is not sort of universal use of rapid testing. It really depends on the level of service that the pregnant woman is being managed in, and it's quite variable. So we have chosen to, in our guidelines, which actually haven't been released yet, but are going through consultation, to say that we think we should have a very quick turnaround for a 4th generation test within the laboratory in the hospital and have that agreed. So the national guideline is that we need to do that turnaround needs to be less than 24 hours. And if somebody presented late and a point of care test was available within that service, then the likelihood is it would be used in combination with a 4th generation antibody test, but always in combination. I hope that answers your question.
Я вам дуже вдячна за відповідь. Тобто ви для тестування вагітних використовуєте тести 4-го покоління.
4th generation tests, right, for pregnant women testing, right?
Швидкі тести або інструментальні методики.
But rapid tests or instrumental methods, which one do you use?
Oh, so in terms of our antenatal screening, it's a 4th generation test that would be processed in the main hospital laboratory.
ELISA, means ELISA testing.
Yeah.
Great. Thank you. Thank you very much.
I can see Annette.
Дякую за дискусію.
Thank you for this discussion, Annette.
Charlie, you presented data that the HIV testing rates in the UK in women are decreasing. And do you have any idea why this is happening? Because you listed all the barriers for women to testing, but I think nothing of that has changed pretty much. So why are the numbers and the rates are going down? That's frightening somehow.
I would agree. I don't know that we really understand exactly why. So that figure that I gave, so these were women that had been offered the test as part of so in our sexual health services, we have more of an opt-out style of HIV testing counselling. So we would just say, oh, this is what we do. Tell me if you don't want me to do it. And I wonder if some of that's to do with, well, I think a large proportion of it is to do with perceived risk. But not just from, I guess, in that setting, because those figures that I gave you were from a sexual health service that would have been using a kind of opt-out approach. So it would have been somebody that thinks that they are not at risk, or I guess potentially as part of a reason there would be stigma and discrimination and fear of what the result would be. And like you said, and I can't see any reason particularly why that would have changed. Maybe with the pandemic and maybe social mixing, people are not perceiving their risk. I don't know. That's just, I guess, speculation.
Do you think it has something to do with reaching out to get the right women tested? Like you said, lots of women are born abroad. We have migrant women coming from countries with a high prevalence, but it's also stigmatizing to contact these groups and say, hey, let's get tested. And like, why? Just because I'm born in another country? So there's a lot of political discussion on migrants already. And this, the atmosphere is you're increasing stigma somehow. So it's really challenging, and it's getting more difficult. And for the general population, if you are talking about a higher risk in migrants coming to Germany, I don't want to imagine what's happening then.
No, but you don't want to do the reverse, do you, of making it worse?
So there might be, even due to the political climate or whatever, the barrier might get higher to get to have access to groups with most probably higher HIV prevalence, and they should get tested. Yeah.
And I think that's where hopefully our emergency department opt-out testing is going to be potentially a real game changer, because that for us in the UK, the way our health system is set up is where a lot of, because it's free, in the same way that if you register with a family practitioner, you often have to show your migration status, etc. But emergency care is free. So that means that a lot of people will be accessing that don't access other types of healthcare settings. And that universal approach means that you aren't it's not relying on somebody to think, oh, I think that person's at risk. It's blanket. And I think so much of that is normalizing HIV testing, and it should just be, in any healthcare setting, if one can ideally get that funded.
Well, it's still something special in Germany. I can tell you, we have opt-in even in pregnant women. So you can imagine what that means. Yeah. But thanks.
Дякую. Дякую за таку дискусію.
Thank you for this discussion. Ms. Tatiana, I have a very brief question, whether we can voice your comment after the clinical case. Just 1 minute. 1 minute. I just wanted to ask Charlie to send the link, if it's possible, to the guidelines.
Oh, yes. Yeah.
British HIV-associated guidelines. I'd be very grateful if you can do that. Thank you.
I'll send it to the conference organizers, and then they can hopefully send it around afterwards.
А ми, в свою чергу, обов'язково поділимося їм з усіма учасниками.
And we will share it with all the participants of our today's meeting, our webinar. If it's okay with you, dear colleagues, let us hear the clinical case, because we will really be interested to hear from our speakers about this case. So This is HIV testing case in a woman who plans pregnancy. Will be provided by Inna Lutsuk, and a couple of slides will be provided and explained by Ms. Tetiana Yelagina. So Ms. Inna and Ms. Tetiana, you're welcome.
Hello, dear colleagues. I would like to offer to your attention a clinical case, HIV testing service for a woman planning pregnancy, no conflict of interest. So Olena's story, she is 43. Since 14, Olena has been married for the second time. Her husband is 36. He is younger. His HIV status is negative, and the couple wishes to have a mutual child. From 5 till 11, Olena was married for the first time. She has a grown-up child, a boy, born in that relationship, 18-year-old. Her ex-husband's HIV status is unknown. Her son is HIV negative. After the divorce with the first husband, Olena had 2 more sexual partners. The sex was unprotected. Partner's HIV status is unknown. She has never been taking substances, including injecting substances, and does not take them now. Smoker for 20 years, has permanent employment, underwent HIV testing as part of IVF planning in 24. In 2015, Olena and her husband were diagnosed with chlamydia and trichomoniasis, and they got treated for that. In 2018, Olena, when she was 38, she got naturally pregnant, but at 6 weeks she had missed abortion, and her blighted ovum was removed. D and C was performed. In 2020, chemoperturbation of fallopian tubes was performed. In 2021, she had surgery for ectopic pregnancy. All interventions were performed at private clinics. Olena insists that she was not tested for HIV and she was not offered that test. In 2023, Olena's husband was diagnosed with oligoastenoteratospermia. In 2024, regardless of the war and difficult times, the couple is planning pregnancy. But considering the oligoastenoteratospermia of her husband, failure to conceive in that relationship before, Olena's age, she's 43, they were offered to undergo IVF using donor sperm. Also, they were recommended HIV testing because of IVF and family planning. So HIV test information and counseling is really important. Who, where, when, how, and what's the scope. So screening test was performed at a private lab with ICLA. It was positive. The sample was sent for confirmation to Kyiv City AIDS Center lab. And confirmatory test was done in a specialized lab by ELISA method using 2 assays from different manufacturers. Test result positive as of 28 February 24. Confirmatory test report included the following. It was sent to the private lab and included the following. Referred to the private lab was anti-HIV 1 and 2 antibodies identified, and recommendation was made to refer the client to the appropriate healthcare facility to link to care. Post-test counseling is really very important. Where, who, when, how. On the 1st of March, 2024, Olena came to a specialized healthcare facility. HIV viral load was performed. It was undetectable CD4 1,104 cells, which is 47%. Blood sample was taken for HIV serological markers, identification by immunoblotting, and the immunoblotting result shows the following, that positive antibodies to glycoproteins, P120, GP41, and proteins P31 and P24. But regardless of the results, Olena did not take her HIV diagnosis, didn't want to believe in it. So based on this data, Olena comes for consultation to our clinic. It was 22nd of April 24. So Clinic of Infectious Diseases named after Gromashevsky. and she did not bring any previous testing reports. So that is why HIV testing was done with rapid diagnostic tests. Negative result was obtained. A result reading in 30 minutes per insert. During counseling, Olena told that since January this year, she underwent several HIV tests with conflicting results, positive and negative, and she was very worried and she had doubts about having HIV. Repeated HIV test was done using rapid tests of the same manufacturer but different batch. Negative result was obtained. And considering the history that we know about Olena and the RDT's results, she had HIV tests with RDTs from 3 different manufacturers. It was done with nurse being present, and I was present as well. So 2 pairs of eyes actually were used. When using the manufacturer 1 rapid test, a result was negative. Manufacturer's 2 rapid tests also showed negative results, but when we used the rapid tests from manufacturer 3, we received positive test result. And these manufacturers are listed according to sequence of tests used in this particular case. And considering the results, she had an HIV test with ELISA. Result was positive. Also, Olena sent the test report with regards to serological markers performed with immunoblotting. It was positive. HIV viral load was undetectable, and CD4 was 1,313 cells, 49%. Antibodies to HCV negative, HBs antigen negative, antibodies to treponema pallidum negative, no complaints at presentation, and overall condition was good. She has decreased hearing since childhood, that is birth defect. And based on that, diagnosis was made HIV infection, and ART had to be prescribed. So the HIV testing service includes successive services that need to be provided along with the HIV test, which is pre-test counseling, HIV testing itself, screening, confirmatory and identification test, post-test counseling, including communication of test results, test report provision with relevant test results, and also referral for clinical HIV diagnosis and initiation of ART as soon as possible. Also, if necessary, other services need to be provided. Also, we have to ensure testing safety for the person tested and staff as well, and also coordination with lab services to ensure testing quality and to obtain correct result is also necessary. So if all those steps were provided in time and in full scope, Olena probably took her diagnosis, and then in this case we would be able to take ART as soon as possible. And I would like to show you the results, test results comparison for rapid diagnostic tests done at Kyiv City AIDS Center Lab. So this comparison was performed because our client has turned asking for that, and it was done as per the contract to compare with the reference method, ELISA method, to compare with ELISA method, ScreenScreen Ultra by RAD. Rapid diagnostic tests were provided by the client, and native blood serum samples were used for comparative testing that were previously tested by ELISA. And also for the same comparison, accessory equipment was used that we have in our lab, like dispenser pipettes, for example. And that equipment that we were using, of course, it was certified by relevant metrology agency, and it was precise. So the first testing was done in April on the 15th, 24. 2 kits of 25 RDTs were provided for this comparison of the same manufacturer but different lots. So out of them, 2 false positive results were found, 1 in each lot. RDT tested positive and Elisa tested negative, not having HIV antibodies. Both serum samples defined as negative with the help of reference ICLA assay, because we wanted just to check whether ELISA was correct, and we used the Architect Abbott 1000M analyzer that we have in our lab. So out of 50 tests, 2 worked as false negative. And next testing was done in the same lab, Kyiv City 8 Center lab. It was done in May, on the 15th of May, 2024. Also, our client has provided 2 kits of 25 RDTs each from the same manufacturer, but a different manufacturer, not the same that was previous time, but also different lots were used. After the first lot testing, there were no discrepancies between ELISA and RDT test results were found. For ELISA testing, GenScreen Ultra system that we have in our lab was used. But with the second lot testing from the same manufacturer but other different lot, none of the 25 tests had its control strip working, and these tests were deemed unsuitable for use. So the same manufacturer, same conditions, same lab, but we have these results. So I would like to say that today in Ukraine, there is an urgent need to implement incoming quality control for rapid diagnostic tests prior to using them. And this procedure for incoming quality control for RDTs needs to be regulated mandatorily on a national level. It should be universal rules for all users of rapid tests. This could be done through the MOH order or some kind of guidelines that need to be followed by all. And this is an absolutely necessary prerequisite to ensure quality of rapid tests that we are using, that we are working with. And also in order to achieve good quality, precision of measurement and a timely provision of results and reports, I believe that personnel providing HTS needs to be involved with external testing quality assessment. And it could be done either to include national providers or to include, which would be the best, to include international providers of external quality assessment. Thank you for your attention.
I would like to say thank you both to Ina and Tatiana for this clinical case, for very transparent and honest description of the problems we face. Of course, we would like to hear the questions and comments with regards to this information, this clinical case. So thank you once again. True. Yes. Such an interesting life experience that happened very, very recently. We would be interested to hear opinions of our today's experts. Dear colleagues, if you have some questions or thoughts with regards to this clinical case, we'd be happy to hear. Actually, I can say that we have all grounds to make a diagnosis of HIV infection, like serological data, that previously twice this woman had 2 ELISA positive tests by ELISA. So all the grounds for making the diagnosis of HIV is something that we have. But that's her story. So different labs, different tests. As far as I understood, this woman, she was referred for HIV testing by the reproductive health clinic. All right, so that reproductive clinic that where the IVF is planned. Hello, yes, it's true. She was referred to HIV testing by the center where she was planning to do IVF. So, in other words, a gynecologist referred her. Yeah, a gynecologist who was planning to do reproductive techniques on her was going to do. So she was given a list of tests. One of them was HIV, and the positive result was received. Yes, the result was positive, but regardless of that fact, Olena continued. Yes, so she was positive first time, and the counseling was done where? I didn't understand. It looks like she was self-referred, but she was given a list of tests in the reproductive clinic. They didn't do the tests on her. They just provided the list of tests. Then she went to the private lab to do the tests. It's like she was not provided care and support. It was like self-referred. In fact, it was not quite self-referred. So, but she came to the private lab, and the screening verification test was positive, but she didn't get a test report. She received a referral to the AIDS center, and she started to go to different labs, and she started to get either both positive and negative results with rapid tests. That's right. No one counseled her. She just received the referral to get tested, but no one explained what are you going to test for and what to do in case you get a positive or negative result. She just received a list of tests, and that's all. So she was doing that together with her husband. So the husband received the result by mail. It said negative, and she was told that, well, please come to the laboratory to pick up your paper report. But no one explained anything to her, so she does not understand what to do in this situation. So her CD is 1,300 and undetectable viral load. So well, how do you convince her that she really has HIV? So it's difficult to convince. So yes, right. So the question, how do you control whether she takes ART? Because she is not sure. She does not believe in her HIV infection. No viral load, high CD4. So maybe she'll just put it on the shelf. The ART drugs, put them on the shelf, and she will not take them. So when she is going to come to you to visit you, she's supposed to come June 11th, because she was once in our clinic. She visited once. Now we communicate via telemedicine because she lives in a different region. But she started to communicate. She started to ask questions. She's interested in ART, but her next visit is only June 11th. So my question is, how do I control whether she takes the drugs? How do I select correct words and to explain that she really does need that ART, that it is not a mistake, that this is a infection that you need to treat. Moreover, she plans pregnancy. Thank you. Olena, would you like? Yeah, and then Annette. So who was the first? You're most welcome.
Elena.
Olena.
Олена, все добре.
Olena, we can see you, right? So wonderful. So you can ask your question. Hello, I'm happy to welcome everyone here. My colleague probably, yes, already probably explained with regards to a patient taking or rather not taking her HIV status and with regards to treatment. But my question, how soon ART is going to be prescribed, and whether, and with regards to control and follow-up, this is the labs. So the question is, so the time from the diagnosis to the initiation of ART is going to be long, and how to avoid such situations in future. Well, she was supposed to come June 11. She lives in a different region. Unfortunately, she cannot make it earlier. So, and first she had to absorb that information in her mind to think it over, but she really wants to take ART because her priority is pregnancy. And she says, I'm getting older and there is war and we don't know what's going to be future, so I want to have a baby. She's 43. Her husband is 36. He is younger, but they don't have children of their own, like their mutual child. They want a mutual child, but of course it's Olena. Annette, what do you think?
Well, as a simple HIV physician, I say that these conflicting results are also confusing me with quite some experience in this field. And in very rare cases, like in that case, you have these confusing results of tests, different HIV tests, and you really have to have a reliable virologist, and which is easy in our university clinic because they are quality controlled, standardized, and you know, we often had false positive tests in pregnant women, quite often, I have to say, through the years. And then we could clarify everything in doing the test again, retesting in our lab. So regular HIV testing, not rapid testing. But what I want to comment on, so I get it. You are concerned that the woman might not take her ART because she does not believe in these results, and it has been a confusing situation. We all agree on that. But she has no detectable viral load, so we don't know if she's an elite controller or whatever is happening there. But I remember former times when we would not have even treated this woman because there is no viral load. Today we would say, well, start ART as early as possible because of the inflammation, because also you never know what might be happening during pregnancy. So we want to stay on the safe side and would start ART. But right now, if we look at the situation, it's not a risk for the partner. She is not pregnant yet. For IVF, it could be feasible right now because there is no detectable virus. And to find out if she's taking her medicine, that's easy because you would probably use an integrase inhibitor so you can look at drug levels. And if there is no drug detectable in the blood, she is most likely not taking her medicine. But I would not do that in the first place. I would just talk to her and explain a little more and give her some more time, because this has really be a stressful situation for this woman, for the couple, and even for the involved doctors. So just stay calm and carry on. I would say it's nothing frightening now because she has an excellent CD4 cell count, no detectable virus. So what? You have some time.
Дякую вам.
Thank you very much. All right. Someone else would probably want to comment. Tatiana, who would like to comment? Miss Tatiana, you're welcome. Dear colleagues, it's not even a question, it's a kind of a clarification. When we just started to work in the area of HIV testing and like scaling up testing, fast track cities in Kiev, we did not do viral load for patients who start ART. We didn't do that. So now we do have that possibility. And we see patients recently who before ART we do viral load and see the undetectable level. And in our lab, we did some experiments. For such patients, we did Western blotting and other methods of testing were used. We have a big lab and we can do that. And everything was positive. So they are really positive, HIV positive people. So that's why this situation is not so unusual. We have already faced cases like that. So what I think, of course, we need to prescribe ART. They had to prescribe ART at the time of first positive HIV test and not to wait, not to measure viral load, not to measure CD4 in the first place, but just in the first place to start ART, number one. Number two, now I think that our colleagues understand more why I was talking about algorithm, why I was asking about rapid tests. Wonderful cat, I love it. That's why our question is not about the discrepant results and we're confused. So the question is about quality, level of quality of rapid tests that we are working with, that people are using in social organizations, at NGOs. They're also using same rapid tests. So it's a global question. So what do we actually do, and how we are losing our patients? I understand this woman because she saw a negative result of a rapid test, and then she gets this report about the positive test from some kind of lab. That's why she does not take this, does not understand this diagnosis, because here she saw it with her own eyes, and the report is something that she never saw. But we are facing that in Kiev, in other cities of Ukraine. We have to think about some mechanism. It shouldn't be something local, but a national level mechanism. So that's why I'm asking some kind of guideline or something, just to understand how to get rid of that problem with regards to quality assessment or for the tests that we are using in our practice. And sorry for talking so long. Thank you, Tatiana. Thank you. Charlotte, Charlotte, you wanted to say something.
The original thing I was going to say, I'm not going to say. I'm just going to make a comment about, I guess, elite controllers. We have a clinic in our university where we're actually like a national referral centre, and we do this same thing. So they get sort of extended Western blot panel. We have access to ultra low viral load testing. We do markers of, I mean, obviously this is very resourced, but markers of immune activation, and treatment in elite controllers is just saved for those that have evidence of inflammation and immune activation or ongoing molecular kind of positivity. But there are a number of them that have no molecular positivity, even at a very, very, very low level. We've just written up a case series from the last 20 years of all the viral controllers pregnancies that we've had in the UK, which I can send to the organisers. That can be sent around if people are interested.
Да, это было бы очень интересно. Спасибо огромное.
Thank you. That would be wonderful if we could receive that information. I also know cases when a woman, like for example now, a woman is pregnant and she is 45. She stopped ART to avoid ARV drugs impact on fetus, regardless of our counseling. It's not that I'm proud of that. I just saying that we couldn't do anything in this situation. She just stopped, and by the way, that's her second pregnancy, the first one at 43. She just does not want her fetus to be affected by ARV drugs. She has more than 1,000 CD4 cells, and everything looks okay. As far as I understood, well, at the institute where I work, Ina works, we deal with opportunistic infections and treatment. We don't do too much HIV testing, but on the other hand, we need to understand the basics of HIV testing. A patient comes and we need to explain everything. So first test is rapid test, and basically we could have give her the report that she's HIV negative, and just give her another HIV negative result report. It's a good thing that Ina listened to her really attentively. So she did 3 tests and then sent it for ELISA. But if it turned out differently, if she just wanted to test us, that woman, and not tell us the whole story about the reproductive plans, about other previous HIV tests, she would just come, gave blood, got the HIV negative result of her test, and just that's all, and left, just increasing her pool of HIV negative test results. What I want to say, of course, we like rapid testing of accessibility and everything, but on the other hand, we want to say we don't want to have poor quality tests. That's what we don't want to have. Maybe it's not about the quality, but some other peculiarities. But here we are dependent on a lab. So that's why I was asking about the diagnosis. At which point the diagnosis was made? No counseling, nothing. And here she comes to see an infectious disease specialist, a doctor who takes the responsibility to make a diagnosis and takes the responsibility of prescribing ART. Of course, support early ART initiation, but Ina and Tatiana also showed difficulties of the process. But of course, it's necessary to discuss and understand where to be tested, where to get the diagnosis. And Ina, it's good for you that you continue working with a woman, that she's followed, but in a different scenario, she could have just left with another negative result and continue her life somewhere in the region where she lives. So that's what we are talking about. So psychologically traumatizing situation. What if the baby would contract her HIV, and then it will be even a more traumatizing situation. So thank you very much. Natalia, would you like to say something, or is enough for today? I just wanted to thank for this wonderful meeting. Thank you for this communication and for being able to talk to high-level specialists from different countries. Hopefully that in Ukraine soon we will have peace and victory, and we will have more opportunity to help pregnant women, non-pregnant women, all people in the country. Thank you. Thank you very much. And just one word to say. I would like the artificial intelligence and digital technologies be involved in, counseling and interpretation of results. What I loved it really very much, this piece of information. It will resolve a lot of issues. I was inspired by that. So thank you, Charlotte, for that. Thank you for telling us about using AI. So digital technologies and AI. Clearly, precisely, everything will be given, all the information is going to be given. I think the future is going to be like that. I support that. Thank you. I would like to give the floor to Annette, Daria, Caroline, and then say goodbye. Love you. Thank you very much. It was a pleasure. My pleasure.
So, Sergey, are you going to end this workshop, or it's me saying goodbye to everyone?
Так,
Нет, я завершувати Caroline і ви, Аннет.
We would like to hear something from Caroline, from you, Annette. Maybe Daria would like to say something. Daria, Caroline, and you.
Okay, should I just start, because I know we are already late, and it's you know, it's so great looking at Sergey. He's always desperately trying to keep an eye on the time and keeping the timelines. We never managed to do so, but it's just because it's so interesting. It's so great to have these lively discussions. And so I would like to say thank you to all the speakers for these wonderful presentations. And I know it's not meant like that, but I always enjoy this workshop because I learn so much, and it's always this great atmosphere and very open atmosphere. That's not so common at every meeting. And I'm really looking forward, even though this is a great virtual meeting, and you're talking about artificial intelligence, but you know, I'm simply wishing to meet you face to face in Ukraine once again as soon as possible. That would be so great. That would be even more lively and a little bit more touchy. So, but thank you so much. And Sergey, I know time management is on top of the list. You made it. Thank you so much. So thanks to all. And with that, I hand over to Caroline.
Thank you, Annette. Thanks to you being chair of WAVE, and I'm looking for a great next year with you. Thanks to Sergey, and thanks to Svetlana for the and thanks to all the organizers, and thanks to all the speakers of today. As Annette has already said, it has been a lively discussion, and we could do 3 more hours. But I think we keep it going, our workshop, that makes it even more motivated to plan the next workshop. It's amazing how we can learn from each other and go on in our daily clinic and keep an eye on things, with knowing that we have colleagues across and friends across the world. So thank you, and I hand over to Daria or Sergey.
Thank you very much. Огромное спасибо за приглашение.
Thank you so much for this invitation. Thank you for the organization of this workshop. I'm a new person to WAVE. It's my first workshop with WAVE, but it was really, really interesting. And the discussion is really interesting. And everyone is so participatory. Everyone is asking questions, and you can say for 100% that you are trying your best, regardless of the difficult situation in the country. I'm inspired looking at you, regardless of the context. Still, you have courage, you have interest to do everything is possible, and you organize conferences, you organize workshops. I'm very, very much hopeful that soon we will be able to meet in Ukraine, on the Ukrainian land, and continue our discussions and our talks. Glory to Ukraine. Glory to heroes. Thank you. So, dear colleagues, huge, tremendous thank you. I could have gone on myself for a long time, but we have to say goodbye for today. The only thing I would like to remind you that the recordings of yesterday's and today's workshops will be available for a couple of weeks, so you will be able to review them once again or share them with someone. Thank you to our participants. Thank you for your time that you participate in our webinars, and thank you very much to our technical team. Regardless of our power outages, blackouts, and whatever, still this team was able to actually to organize this. And thank you to our translator, who actually allowed us to understand each other. So, dear colleagues, thank you very much once again. And our next webinar is going to happen in September. So, summer vacations, and then in September, we will continue. We'll be happy to see you again. Once again, thank you. Goodbye.
Thank
All the
you.
best.
Goodbye.
Goodbye.
Take care.